Assalamu alaikum warahmatullahi wabarakatuh and good evening to all our viewers. Welcome to Urgent Spotlight. My name is Azrul Khalib. This is a series of online talk shows where we will be covering how the various policies and actions implemented have impacted today's urgent issue: workers' welfare, the urban poor, refugees, education, indigenous people, migrants, and of course, healthcare. The agenda for Urgent Spotlight is policy reform and holding the government, policy and decision makers, and yes, even the public accountable. We are broadcasting live every Tuesday and Thursday at 8:30 via the CSOP4R Facebook page. Health authorities reported 20 new COVID-19 cases today, dropping from 38 yesterday, bringing the cumulative number of cases in the country to 7,877 so far. Health Director General Dato Dr. Noor Hisham Abdullah said out of the 20 new cases, 15 were reported cases, while 5 were local transmission cases. This marks the lowest locally transmitted number of cases, a milestone since the COVID-19 outbreak began in Malaysia. A couple of days ago, the Ministry of Health announced key findings from the National Health and Mobility Survey 2019. Amongst its many points which bear discussion and debate, despite public healthcare being vastly subsidized with the RM1 and RM5 fees for outpatient and specialist fees at Ministry of Health facilities, which has not changed for nearly 4 decades, Malaysians have been found to be spending more of their monthly household expenditure on health. More people are spending their life savings treating diseases which could have been prevented, such as type 2 diabetes and chronic kidney disease. The COVID-19 crisis and now the survey's results are bringing to bear the importance of ensuring that we make suitable investments in health, particularly in the area of public health. What lessons can we learn from the COVID-19 response? Have we left anyone behind, especially vulnerable and marginalized populations, in the move to contain and manage the spread of the coronavirus through lockdowns and social restrictions? Will issues such as the increasing spread of non-communicable diseases such as diabetes and cancer, and the increase of risk factors such as obesity be less of a priority for Malaysian healthcare in the face of the ongoing COVID-19 crisis? To help answer these questions and to provide some insight into what is happening today on these issues, we have with us this evening Professor Dato Dr. Adeeba Kamarulzaman. Prof. Adeeba is Dean of the Faculty of Medicine and Professor of Medicine and Infectious Diseases at the University of Malaya. She has had a distinguished career in the prevention, treatment, and research of infectious diseases such as HIV/AIDS. She is also a strong advocate and pioneer for HIV prevention, treatment, and care programs in marginalized communities. In 2007, Professor Adeeba established the Center of Excellence for Research in AIDS, or CHURIA, at the University of Malaya, which is one of the few dedicated HIV research centers in the region. She is chair of the Malaysian AIDS Foundation and is president-elect of the International AIDS Society. Welcome, Professor. And if it's not still too late, Selamat Hari Raya, Maaf Zahir Batin.
Selamat Hari Raya, Maaf Zahir Batin, Azrul. How are you?
So, very well, thank you. Thank you for being with us on the show this evening. For viewers out there, please do send your questions, and we'll try to get them answered during the course of today's show, and perhaps if we have a little bit more time at the end of our discussion. So, Professor, let's start, shall we? In your opinion, how has the Malaysian healthcare system, both public and private, responded to the COVID-19 public health emergency? How do you compare us to the responses of other neighboring countries in the region, such as South Korea, Singapore, and Thailand?
Hi, Azrul. So I think you will probably share my assessment of our response. And overall, I think it has been very good, and we can be proud of it. I think certainly most of the countries in the region have done very, very well compared to much more developed and economically advanced countries. I think one of the things that we know about what we've learned about the COVID response is the heterogeneity in the epidemic. How our epidemic differs from that from Thailand, how it differs from what's happening in Vietnam, and there's a lot of similarities with Singapore. But overall, yes, I think we can be proud of what we have achieved thus far. Of course, there are areas where we can improve on, and we must keep our eyes on the migrant workers, on the illegal migrants, and those highly vulnerable groups.
So there's been a lot of questions in other webinars that have been asking, what is Malaysia's secret sauce, as it were, to the success that we've had thus far? I mean, we managed to keep the number of fatalities especially quite low, and certainly, on the issue of hydroxychloroquine, for example, we're using it here, but other places it seems to actually cause more fatalities. Yet Malaysia seems to be all right in terms of using the kind of treatment that has been, rejected by other countries. So, what is it that puts us apart in terms of our response compared to the UK and the US, which seems to be quite bad and experiencing quite a number of fatalities as a result of their outbreak?
Yeah, so I think there are several factors. The most important one being that we acted very quickly to the news of the epidemic in Wuhan, China. We started, closing our borders to countries. We started defining criteria for testing patients who might be infected with COVID very early, and once they were diagnosed, we isolated and treated them and did contact tracing way back in January. And if you compare that, US and the UK only started reacting in March. And even then, if you speak to colleagues in the US and UK, testing to diagnose is still extremely difficult. And this is something that, both the public and private health sector provided very, very early on. Testing was really pretty widespread. So by diagnosing patients early and admitting them into hospital, and one can argue whether we might have gone a little bit overboard in terms of admitting every single person into an acute care hospital, I think we were able to manage the patients well, and but yeah, I personally think that's the secret sauce. Certainly, in our own hospital's experience, by admitting, patients early, we didn't have that many compared to Sungai Buloh, but we managed overall slightly over 100 cases. Because we were able to monitor the patients really closely, and eventually, when the few that we had developed the cytokine storm, we were able to mitigate the severity of the disease with some pretty experimental treatment, and also managed the respiratory failure very, very well. So although we had 6 deaths, one was in someone who came in very severely ill, and the others were in very, very elderly patients.
So we know that for the public, the Malaysian public's experience of the COVID-19 crisis has really been from March onwards to today. But as you said, Malaysia responded, especially the public health system, responded quite early on, arguably even late December, where already there was an alert that was going around, and certainly precautions were being recommended. And later on in March, where the MCO was then imposed, and now we have the CMCO, is the public's experience. So we've heard a lot about the need for having these restrictions, and certainly one of the things that the public needs to understand is what was achieved. What did we gain from the sacrifices that we made during this period? What did we actually gain from the MCO and from January up to this point?
Yeah, so I think three important things that we gain. I mean, the one thing that the public must remember is that the MCO or the lockdown or whatever you want to call it was never about eradicating the virus completely. I think this is a really, really important message for people to remember, so that they will continue to take the necessary precautions for many, many months forward. The whole aim of the lockdown is to flatten the curve, and that was to reduce the number of people getting infected as much as possible from getting infected at the same time as what you see in the US and the UK, when you get this a huge number of people getting infected at the same time, because there's free movement, there's this ongoing transmission. You run the risk of overwhelming the health system. So that was the main aim of the lockdown, to minimize the number of people getting infected. And by doing that, you allow the health system to prepare itself, to get the adequate number of PPEs, to put in the guidelines in place, to make sure we have enough ventilators and so forth, which by and large we achieved, right? And the second, I think, achievement from the lockdown, although albeit, all this at extremely high cost economically, is to create that awareness in people's minds. And I think, Azrul, you've been in this business for a long time. The most important thing is behavioral change, right? To achieve behavioral change is so difficult. And in a way, I don't think that was the aim of the lockdown, but what it did was achieve the necessary, manage to get the message, I think, to a large number of the population that, hey, this is serious, hey, you need to take personal responsibility, that these are the ways in which the disease can be transmitted, and this is the way you keep yourself and your family safe. And I must commend, I think, the public health messages that you see on TV are really excellent, especially the infograms and all of that. So to the point that I think there are segments of society that are still very cautious about going out, which I think is all good. So those are the three things that we've achieved. We've minimized the number of people getting sick at the same time. We allowed the healthcare system to be prepared, and we got the message through, I think, to a significant segment of the population.
I think the third point there is something that we really haven't been able to really appreciate as much, and certainly when we look back on some of the achievements that we've made, this will definitely stand out, I think, as something that we've been able to achieve that is, aside from an authoritarian form of government, we've been able to have this in the Malaysian system. So let me ask you, obviously this response has brought out quite a lot of effort from the healthcare system as we know it. It's put us into a stress test, so to speak, and has it highlighted strengths in our healthcare system, which we didn't really previously consider? Is there anything new that we didn't know before or didn't emerge before? And what have we learned from dealing from other epidemics such as SARS and H1N1, influenza A, that have actually influenced the Malaysian response? And especially yourself being a infectious disease physician, you're very much knowledgeable in this area.
Yeah, so I think certainly the SARS, although we were quite lucky with the SARS-1 epidemic in that the number of infections here was very limited, but we certainly had to respond very quickly and very widely with H1N1, and I'd like to think that the experience from there, allowed the Ministry of Health in particular to be very prepared. But we must also remember that years of living with dengue and malaria and other infectious diseases have also prepared the public health system, the PKDs and others, in terms of the contact tracing and so forth and so forth. So that was put into action, and Ministry of Health personnel, from nurses to doctors, public health practitioners, all did extremely well, and must be congratulated. Likewise, with the acute care hospitals, from Sungai Buloh to all the state hospitals, everyone came to the fore and just gave their all, basically, and it's a testament of the resilience and the competence in the system that we've managed to do it very well.
So there were a number of points that you mentioned just now which really stand out, and certainly contact tracing being done on a scale never seen before, arguably something that we've had to train our contact tracers rapidly to be able to do their jobs well, but also to be able to effectively develop the epidemiology, the picture of where the outbreak is. Certainly, even when the numbers were in double digits already, you could see quite effectively, I think, the case 23, I think, where
26.
26, yes.
23, 26, yeah.
Yeah. So
I can't remember,
it was quite,
because 23 is one of my colleagues, so 26 is, so I get them two mixed up. But anyway, yeah.
Yeah, so it's one of the things that I think students of epidemiology are going to look back and see this is where we really learned quite a bit from this experience, and certainly we'll be able to apply them for future epidemics. But going back to the issue of fatalities.
If I may
please, go ahead.
there. Although I think we did extremely well, if there is a lesson to be learned, and if, I think although we did very well, we must never rest on our laurels, because if you read, people, world experts will say this is not going to be the last pandemic, which is a pretty scary thing to hear. If there is room, if we want to consider room for improvement, this is also where it is. I think if you speak to people on the ground, the manual way in which we recorded the cases, and the actual manual way in which we did the contact tracing are all areas for improvement.
It's quite labor intensive, I think, and it's certainly, when you look at the way South Korea does it, they've actually moved towards digital contact tracing there.
I think these are the areas where we need to seriously, post-COVID, when things settle down, need to look at in terms of preparedness. How can that be improved? Of course, with the digital contact tracing, there are concerns around data privacy, etc., but I think in good time we can all come up with a good solution, I think. So, and those things can be used for contact tracing for other diseases like TB, like dengue, which are going to be around for a long time to come. Yeah.
No, absolutely. I think when it comes to the area of infectious disease, we're going to see more, not fewer, new pathogens that are going to emerge, and certainly this is like almost a warm-up, so to speak, and perhaps we'll be facing another one in the years to come. But we've been fortunate to have very few fatalities due to COVID-19, despite there being thousands of confirmed positive cases. And as you mentioned just now, and we've discussed, is that it's the decades of investment in our public health system and our experience in infectious disease have actually produced what we see today. The results that we are able to say that we've been able to protect our citizens, we're able to protect the people who are living in Malaysia, and to also have a fact that we can be proud of. But I have to ask you, Prof. Adeeba, are we in danger of being complacent, thinking that we've done enough in infectious disease preparedness because we've got such a result?
Yeah, so as I said before, we must never be complacent, because as you can see, these viruses and these pathogens are in many ways, even with our brain, are in many ways much cleverer than us and evade us, and has brought the Americans to their knees, for example. So we must never be complacent. There are lots and lots of areas for improvement. I mentioned the manual contact tracing being one of them. I think we need to have a system in place for active surveillance for these kinds of infections. A rapid alert system. We certainly could have done better in terms of preparedness with PPEs, for instance. There was at the very beginning a scrambling for PPE. There has to be this is one area where I think a look back, a central stockpile of necessary equipment, whether it's PPE or ventilators or what have you, and a central distribution system, because at one time it was almost like every man for himself. And I think greater involvement of the private sector would be nice. And even my colleagues in academia, greater involvement early would, of other teaching hospitals, of other labs at a very early stage, a truly kind of collaborative response at the early stages would, I think, have been good as well.
Actually, this is a really
testing, because it was a while before I think the labs got going, and there were delays in results because it was mostly concentrated in only a few labs. So those are some areas that I can think of off the top of my head, that if we do a post-mortem of all this, some things that we need to strengthen and even put in place, so that if something like this happens, at a push of a button, it's go.
I mean, this is an important point, because our belief in the concept of public-private partnerships were really put to the test, and it was a trial by fire, basically, having to immediately. There are a lot of people coming forward to say, let us do things, and the Ministry of Health was saying, we don't have it in place yet, we don't have the protocol, please wait, please wait, please wait. And we lost valuable time there. And that's where a lot of people, a lot of private hospitals also, I think, were not reluctant to contribute to the effort, but it was really the ministry, the government not yet prepared to adopt that into the system of response that we had. And I think we've learned quite a bit since then, and perhaps.
And I think guidelines and all that could have been shared a lot earlier.
So the government has put together.
My charger. Give me 2 seconds.
Oh, okay.
All right. Sorry about that. Oops. Okay. Go on.
Yeah, no worries. Welcome back. So
Sorry about that.
It's quite all right. The government has emphasized that the approach that is taken now in terms of screening is a targeted approach, and it has focused on specific populations such as migrant workers, the elderly and assisted care facilities. And yesterday, there was a confirmed case in Sungai Buloh prison where now 700 staff and 800 prisoners are now being screened for COVID-19. In the future, when we're dealing with marginalized and vulnerable populations, what can we do better? How do we prevent leaving anyone behind? Your thoughts?
Yeah, this has been something I think I've been sort of mentioning on my tweets, both my concern about infection in the prison in particular, because, you know, we have projects in Kajang prison, and we all know prisons are overcrowded. You know, it's very difficult to practice physical distancing and hygiene, etc., etc. And in the case, well, and we've been calling for not putting more people into prison, especially for non-violent offense, to delay sentencing, and some of the, and even to decarcerate. Many countries around the world have released prisoners who are non-violent offenders, either with those with very short sentences or those who have been in prison for a very long time and are safe to be released. I mean, those details can of course be worked out, but we need to seriously think about reducing the overcrowding, because it's now at 125% or more across our prisons. In terms of migrants, documented or undocumented, again, learning from the HIV epidemic, it is best to work with the communities themselves and the NGOs when it comes to the marginalized communities, because there's trust. You've got people who speak the same language, not just in terms of linguistic, but, you know, in terms of understanding the needs, the fears, and in this sort of situation, you can't take the strong arm big brother approach, because as you can see, people are already going underground when you do that, which kind of defeats the purpose of the public health response. So,
well, let me pick you. Let me take you up on that, because we have a question from one of. Oh, sorry. Okay.
yeah.
So we have a question from one of our viewers. How has the impact of NGO or civil society organization assistance been on the management of COVID-19, working together with government agencies? How do you see it?
Say it again. Can you repeat that, please?
How has the impact of NGOs or civil society organizations in the response towards COVID-19, working with the government agencies?
Yeah, I think, you know, in the early stages, NGOs like Imaret and others were very active in helping out with with supplying PPEs, and that has been the most obvious input from NGOs, you know, in working very hard to ensure the safety of healthcare workers. And on behalf of all healthcare workers and frontliners in the country, let me thank everyone for working so very hard to ensure that all of us remain safe. Regarding working with marginalized communities, I think we can do better. I think we really need to sit down at the table and discuss this, because this is going to be the long haul. You know, we're not going to just stop in the next few weeks, because we have to believe that the virus is going to remain with us for a long time to come, until we get the vaccine or we reach herd immunity. Okay. And so ongoing education and even assistance with bringing people forward for testing will require working hand in hand with NGOs and CSOs.
Well, certainly one of the points that we've raised is the critical role that's being played by our healthcare providers and people such as yourself who have been every day at the hospital providing the kind of supervision but also the care for not only people who are positive for COVID-19, but also the ongoing uh, treatment for diseases that still exist despite us having this COVID-19 outbreak. I mean, life still goes on. Babies are still being born. People
Yeah.
still, get into accidents even though they're not supposed to go anywhere. And people are also suffering from non-communicable diseases. So I'm going to move a little bit from COVID-19 towards a major issue that just came out a couple of days ago. The Ministry of Health released the findings of the National Health Mortality Survey 2019, and it found that 1.7 million people currently live with three NCDs, diabetes, hypertension, and high cholesterol, and 3.4 million live with two NCDs. So 50% of the population are either overweight or obese, and these are startling statistics by any measure. If you look at it,
Huge. Yeah.
it's huge. It's a percentage of the population that is, if you combine the two, we're looking at 5.1 million people, which is already more than 10% of the population. So when you look at Malaysians, they don't seem to be worried. And I think they even resigned to it. They seem to be even fatalistic. So what's going on and what can we do to change this? Your thoughts?
What's going on? We love our nasi lemak and roti canai too much. Yes, this is a crisis. This is a crisis that's going to cost us all dearly in terms of lives lost, in terms of limbs lost, and in terms of money. Yeah, in terms of financial cost to the government. There needs to be a much more concerted effort into addressing this. I think if we could get people to be as afraid of diabetes and obesity as they are with COVID-19, we would be doing well. I mean, I tweeted a recent study that 10%, something like 10% of people who were hospitalized in this study in the US who were diabetics died within 7 days of admission. I mean, when we know that diabetes and obesity are two of the major risk factors for morbidity and mortality with COVID-19, and we know what drives it. It's the inflammation, and actually we know that it does the same things to diseases like dengue and so forth. So having diabetes and being obese is life-threatening beyond just all the other risks or all the other complications that you hear of, of having heart attacks or strokes. And so even in acute infectious diseases, these two conditions worsen compared to someone who doesn't have diabetes or obesity. So it's not a simple thing to address, but address it we must. I mean, like 20% it's terrible figures, and especially amongst young people. I mean, I was just with one of our pediatricians a couple of days ago, and we're seeing more and more young people with type 2 diabetes. I'm talking about 10-year-olds having type 2 diabetes. Imagine the cost of it to this young person, but also to the health system. So perhaps after COVID, we all need to take a deep breath and sit down and put our heads together and really look at how we tackle NCDs. And it will have to be it has to be tackled from all angles, from perhaps sugar tax to massive education campaigns to restricting, I don't know, different things. But whatever it is, it should be evidence-based, and there's plenty of evidence out there, and plenty of evidence to be learned from local research on what works to
Well,
tackle the
Professor,
problem.
one of the
If I had my
problems
life
has
again, I would
been
go into diabetes.
uh, no, you need it in infectious disease, I can tell you.
In
Uh,
HIV. But there are also things that make this difficult to tackle, because one of the, I think you and I know that excess ingestion of carbohydrate makes diabetes and obesity worse, and there are links to low income and low knowledge in terms of people eating carbohydrate because it's too much carbohydrate because it fills the stomach
yeah.
versus other healthier food. Yeah.
Let me take you up on that because one of the main issues that was highlighted in the NHMS is health literacy and how low it is amongst Malaysians. And
It is.
we've seen this coming to the fore with COVID-19, where at the very beginning of the year, we had people spreading different things on WhatsApp saying this about COVID-19, about that remedy, this cure. Even at one point, the Ministry of Health had to respond to a worry that COVID-19 could cause people to become zombies, which is quite out of there. But health literacy is key to ensuring that people understand health risks, practice health lifestyle, understand medical information, and make those decisions concerning treatment and care. So we know this, but do we emphasize enough about the need to learn more about our own health, or do we simply just do whatever the doctor tells us to do and just leave it at that?
Yeah, so there is a bit of that. There is, in our society where it's very paternalistic that, doctors know best, still exists. So we need to move away from that. And we need to utilize social media. We know that's where people are these days. So, and those things are relatively inexpensive. So, in terms of compared to billboards, which don't work anyway. So getting smart people together to think about how can we penetrate the public with messaging around healthy living, healthy eating, exercising would be super important. Yeah.
But if you wanted to invest money and want to look at building new systems to invest in the kind of health infrastructure that is able to prepare us to deal with NCDs and also incoming pandemics such as COVID-19 and future H1N1s and influenzas and so forth, where do you think the investment should go into? We have so many needs. Primary care.
Primary care. There needs to be strengthening of primary care and the public health is in public health system. But primary care is where the public goes to, and it should be there to provide preventive care as well as primary care as we know it. Thus far, I think Malaysia has put a lot of investment in secondary, tertiary, and acute care. Built lots of hospitals, but the focus now should shift towards strengthening primary care and improving. Well, first of all, the 20% of people who already have diabetes, making sure that their management is good to reduce the complications, making sure that they get the right health education and everything else, and dietary advice and lifestyle advice and all that. So all that should already be happening in the primary care sector and system.
But we do know that the government puts a lot of money into the healthcare system right now. I mean, there is some debate as to it not being enough.
4% of the GDP, as opposed to we should be around probably 7 or 8.
Yeah.
Yeah.
So
So
it
it sounds
is
like a lot
taking
of
up the
money, but
third.
it's still probably not enough.
Yeah, it's already the third largest budget item on the national budget. But also, when we look at it, is that we should be looking at putting in uh, resources to enable for the public to actually gain more services. So, if we were to look at it, the public utilizes and depends on the public healthcare sector. It's more than 70% of the population uses the public sector. Yet we also have an imbalance because the private facilities are also part of Malaysian healthcare, but you see fewer people accessing private healthcare because it's thought to be less affordable. And there is a certain amount of reliance and dependence on the public facilities such as yours at University Malaya Medical Center and Ministry of Health healthcare facilities. So we need to look at healthcare in Malaysia as a whole. How do we go about integrating the two halves of the Malaysian healthcare system to act as one, to function as one, so that we can ensure that the public is able to access either one or whatever choice that they may have? Because right now we're looking at a disparity in access.
Yeah, so several things need to happen. I think the first would be to re-examine the health financing system, which has been the Achilles heel. There have been, if I'm not mistaken, 21 different consultations on what would be the best health financing system we should have. The RM1 that 70% of the public are paying to access the KKM facilities in clinic kesihatan is not going to be sustainable in the long run. So I think until we fix that, it's going to be very difficult to kind of level the overcrowding in public system versus the 70% of specialists or maybe not 70 but 40% of specialists in the private system that's looking after 30% of the rakyat.
Yes.
So I think the first thing that needs to happen is the re-engineering of the health financing system. And number two is strengthening, like I said before, the primary health care system in both public and private. And, there are lots of GPs currently. You see the overcrowding in clinic kesihatan, and GPs are, private GPs are underutilized. So, having a mechanism to draw people to the private GPs. I think there's been attempts with PERCA B40 and programs like that in the past. So these needs to be looked at in further detail. And I think also, again, working with CSOs and community-based services. We don't do that well enough. We don't finance and strengthen our NGOs who are providing these services, particularly for chronic conditions. And as we face the other crises, which is the aging population, we need to work with community-based organizations to provide that support for the elderly, to provide that support for the disabled, but they need to be compensated for it. For example, the Malaysian AIDS Council, partners organizations of the Malaysian AIDS Council are being supported to some extent. We could do better to carry out programs on behalf of the government. And I think that kind of model needs to be extended to many other organizations out there who are providing care for the disabled, providing hospice care, you name it. So some kind of mechanism to provide financing as well as program monitoring and evaluation so that NGOs become professionalized and part and parcel of the health system is going to be very important moving forward. Yeah.
I definitely cannot agree with you enough on that. There's been so many lessons that we can learn from the HIV experience, especially managing the Global Fund. But when we're looking at how we've responded towards the COVID crisis, as well as the ongoing NCD crisis, obviously the public has very high expectations and they have high demand of public healthcare services. So in the future, if the government were to deal with this, how do you think the government should respond?
Well, I think we've touched on a lot of that already. You know, there are, although, you know, like what we said from the beginning, on the whole we've responded very well, but there are many areas where we can improve, and I think a true partnership between the Ministry of Health, academia, private practitioners and NGOs and civil society would be important moving forward. I think there was a feeling like at the beginning that it was only Ministry of Health responding, and it probably would have lightened the load for them if everyone was brought to the table and to strategically look at where the gaps are and where different parties can play a big role. And none other than, I think, the struggle that we're having at the moment with migrant workers, undocumented migrants, etc. And as I keep saying, you know, NGOs play a huge role here, but that partnership needs to be strengthened and compensated, I guess, monetarily.
Well, thank you very much for that last point, Prof. Adeeba, because I think what we really should be looking at moving forward is a spirit of collaboration between the Ministry of Health, the government agencies, with civil society and the private sector. Because at the end of the day, you don't want them to be going at it alone and thinking that the burden is entirely on them. And certainly from COVID-19, there's so many lessons that we can actually adopt into creating frameworks and guidelines for us to be able to work better in the future. So I thank you very much for emphasizing on that, and certainly we hope that those people who are listening to us this evening will be able to be cognizant of that point and certainly take it up for future discussions. So thank you, Professor Dr. Adeeba, for being our guest for this evening. It has been an honor having you. It always is.
Thank you.
So, ladies and gentlemen, that ends this evening's segment discussing Malaysian healthcare. Please tune in to the Bahasa broadcast at the same time on Thursday night, where we continue this conversation with Professor Dr. Luqman Hakim. This is Azrul Khalib signing off. Good night.